Welcome to Fluorescene.
Hello, and welcome to Fluorescene show number 18. Don't forget to hit that red subscribe button below so you get notifications for future shows, segments, events, contests, and soon to come, COPE. That's right, we'll be starting some free online education and tying it to the Fluorescene. So make sure you're in the loop by subscribing. This week in Odie's on Facebook, a doc saw this sign at Hobby Lobby and is thinking about getting it for the exam lane. This post brought out all the old military vets who, thanks for your service, and docs who have cared for military vets. You know, the people who read the chart, Echo Foxtrot, Whiskey Tango, Zebra Airplane. Look, just say it, so us non-military docs don't have to glance back at the chart to translate and confirm the letters. Please. Then, when someone is reading the lines fine and all of a sudden they go silent, our go-to thought is they can't see the next line. Not always true. This happened to one doc, so he said, "Go ahead and guess, or has it gotten too blurry for you?" And the patient answered, "No, I just can't think of a word that starts with P." Then just say effing P. But don't be so hard on those old military vets. They're using the NATO phonetic alphabet. That's what it's called because that's how they're trained. Don't worry, we love and respect all the branches of our military, and they love to pick on each other too, not just me. If you ask someone in the Army, they'll tell you USMC is an abbreviation for Uncle Sam's Misguided Children. If you're a Marine, they like to say the acronym for Army is Ain't Ready for the Marines Yet. Then there was the doc whose patient read the letters using abbreviations from the periodic table of elements. Serious eye roll. One doc said, "Just reading this made my eyelid twitch." Now, if you wondered why we drink, a doc posts about an established mid-40s patient who, before the start of the exam, says, "Doctor, I'm so grateful for you. You saw my son a few months ago and diagnosed him with Stargardt disease and referred him to the retinal specialist." That's what we do. "I can't thank you enough," he went on to say. Guess what happens at the end of the exam? A few scenarios are probably going through your head. They probably have to do with the patient asking to take the prescription elsewhere. And you'd be right. The patient asks to fax the RX to Costco so I can save a little money. Apparently, gratefulness only goes so far. These are the same people who own local small businesses with a "shop local" sign in the window, right? The type of patient who is so cheap, when they die, they go towards the light and turn it off. So cheap, she takes off her glasses when she's not looking at anything. So cheap, she eats cereal with a fork to save milk. And I could go on, but I won't subject you to that. This is the type of patient that, if you went out of business, they'd be in shock because you're such a good doctor. And they wouldn't understand that they are part of the reason. Docs chimed in with good advice like, "This is exactly the reason we need to charge appropriately for our fees and not care about materials as much." The next post goes like this. Patient who, by the way, owns a car dealership asks, "That Retina photo for $29, isn't that just a gimmick to get you more money for the eye exam?" Doc responds, "No, the dealer's service charge is a gimmick to make you more money for selling a car. The Retina photo is to look for disease, signs of macular degeneration, retina tears, detachments, signs of hypertension, diabetes, brain tumors, etc." And the patient says, "Okay, doc, you talked me into it. Go ahead and do it." One doc said the doc should have offered him an extended warranty at $29, and once he said yes, added, "per eye." Hey, as a used eye salesman, I take offense to this post. Reminds me of the joke where this guy is talking to a salesman and asks about, does the car have cargo space? And the salesman says, "No, car no do that, car no fly." You could have also tried to sell him an extended eye warranty or a retina undercoating. Look, don't be too hard on used car salespeople. It's their lot in life. Then there are the patients with history of cataract surgery who don't remember having the surgery and even deny they have an IOL in their eyes. We've all seen that. The conversation goes like this. "Have you ever had any surgery or trauma to your eyes?" And they respond, "No." You get the slit lamp out, you do a double take. "Okay, so you have a corneal incision scar and you have an IOL in both eyes?" They respond, "Oh yeah, that." Maybe the aliens are fixing cataracts during abductions now. Then this happens. Patients who you ask, and they totally deny it. No, doc, I never had a cataract out, and you're looking at the IOL and the incision scar. Okay, right. Then how did this piece of acrylic end up precisely in the place where your surgeon would implant it? Aliens again. And patients who will tell you the surgeon took them back in the OR and did absolutely nothing, and they're pissed about it because maybe they never felt anything. And you have to spend your time convincing them how much better their vision is since the surgery. Hey, and what about the follow-ups they went through? What were they for? It's kind of hard to forget an operation where a doc is coming at your eye with a scalpel, don't you think? And the opposite can happen too. There's the patients who didn't have cataract surgery and are adamant that they did. You see all types in optometry. Then there was a doc who had a patient who reported no history of eye surgery. When the doc revealed one eye was no light perception and slit lamp revealed a prosthetic, yeah, I think it's pretty tough, even impossible for a patient to forget they were enucleated. But apparently it happens. A member asked, why do patients show up for contact lens follow-ups without contacts, even after we tell them repeatedly during INR and write it on their appointment card? This is like asking how many licks it takes to get to the center of a Tootsie Pop. There's no answer. The world may never know. I hate when you ask a patient why they didn't bring them in, and they answer, because they didn't work. Ugh, makes you want to kill somebody. Short on the concept of follow-up. A doc mentioned the mother who bringing her daughter in for a contact lens follow-up, who showed up for the appointment and, no, she didn't forget the contacts. She forgot the daughter. Parent of the year. But don't feel so bad. We're not the only profession dealing with this. A doc had a conversation with a patient who was a car mechanic, told him contact lens patients come to follow-ups without their contacts, and asked the mechanic, I bet people who ask you to fix their car don't leave the car at home. Guess what? The mechanic replied, yep, happens every day. Head scratcher. It's like going to the Apple store to get your iPhone fixed and forgetting your iPhone. Then a doc asked, who had the best exam room stories? Now, I'm sure we all could have contributed to this, but here's a brief breakdown of the best. There's the doc who hog-tied a child with a belt, handkerchief, and tie to the chair in SCO clinic. I guarantee that didn't happen in the past 20 years. And the doc who had one patient tell him she does not wear bras because they are uncomfortable. The doc hadn't asked if she wore a bra. That's a clear case of TMI. Then another lady told a doc that her contact lenses were uncomfortable, like thong underwear. Again, TMI. And the doc who had an 80-year-old lady tell him after turning down the lights for the exam, it's been a while since I've been alone in the dark with a man. Hey, some of us can't afford to be so picky. Now, plenty of us have farted in front of patients, right? No? That was just me? Oops. And the doc whose female patient lost her husband, and he said, I'm so sorry for your loss, to which she responded, why? He was a mother effer. I can't believe the cops didn't suspect me. Did not see that one coming. Then there was a doc who had a patient come in with a wheelchair and crutches. Guess what happens? The doc knocked the crutches over in a way that jammed them into the spokes of the wheelchair. The building heating engineer had to come in and take the wheel off the wheelchair. Disabling a disabled patient. Yikes. Good job, doc. Then, well, there's the patient convinced her sudden onset floaters were worms. To corroborate her story, yeah, she pulled out a sandwich bag of worms she collected from her stool that morning. And the patient who ran out of the exam room with the gonio lens still stuck on her eye. Yeah, they can be tough to remove, but imagine a patient running around your office screaming and flailing their arms with a lens like that still stuck on their eye. It's like a scene out of a post-apocalyptic movie. Not a great patient retention strategy. And the doc who had a young woman come in saying that a few days earlier that a fly had flown into her eye, and ever since then she had felt things crawling in her eye. When the doc looked through the slit lamp, she almost fell off the chair after seeing small larvae crawl right across the front of the patient's cornea. Over the next 3 days, the patient removed a half dozen more larvae from her eye. Needless to say, doc didn't take lunch that day. Then there was a doc who had the patient who asked if he could get glasses in an hour because, yeah, he had to go turn himself into the police that day. And then the time a patient wore an America's Best t-shirt to a doctor's office for their exam that wasn't at America's Best. That's another head scratcher. Then there's this, the optical illusion of the day. Now that is awesome. I have the head for it too. Some people already think I have a black hole in my head anyway, so I probably wouldn't need the tattoo. But really, I need a tattoo like I need a hole in a head. The best comment? If I was drunk, I would get myself killed trying to throw a peanut in it. The head tattoo bothered me less than the neck tattoo. You know, men with neck tattoos used to make me nervous. Now, they make me lattes. So we've got a great show for you today. Great. Dr. Jill Autry, beloved podium speaker, author, partner at the Eye Center of Texas in Houston, and owner of Tropical CE Conferences, is here. We also welcome Dr. Art Epstein, legendary lecturer, thought leader, and author of Optometric Physician, as well as the founder and chief medical officer of the Dry Eye Center of Arizona. We welcome back Dr. Jim Finelli for another segment of CE and Italy's Tuscan discussion. And Dr. Keith Slayden is back with another interesting episode of Retina Rocks, where he presents a case on major vision problems for a new mom and more. So sit back, pour yourself something as long as it's not Fluorescene on your patient's white blouse, and enjoy today's show. I'm here today with Jill Curran Autry. Jill received a bachelor's degree in pharmacy from the University of North Carolina, Chapel Hill. After graduation, she served as a clinical pharmacist at Cape Fear Valley Medical Center in Fayetteville, North Carolina, for several years. In May of 2000, Dr. Autry graduated from the University of Houston College of Optometry summa cum laude. She was elected to Beta Sigma Kappa for her outstanding educational accomplishments and inducted into the Gold Key Leadership Society. Dr. Autry also won numerous awards at the college, including the Texas State Optical Scholarship Award, the Deborah Adler Grinberg Award for Research, the SIBA Leadership Award, and Varilex Optometric Scholarship Award. Dr. Autry is a partner at the Eye Center of Texas, a 6-location optometric referral center providing secondary and tertiary multidisciplinary ophthalmological care in Houston, Texas. Dr. Autry is a highly sought-after lecturer nationally and internationally on both pharmaceutical and oct disease topics. In addition to her professional career, she's married and the proud mother of 2 boys, Cooper and Bowman. Together with her husband, Stuart, they run my absolute favorite conference of all time, Tropical CE. Tropical CE is dedicated to bringing cutting-edge continuing education combined with exotic destinations since '97. It's at tropicalce.com. Now, I've gone on 5 of these since the early days, and as far as I'm concerned, if I got to get CE done, it's going to be done in walking distance of umbrella drinks and palm trees. So that's how I rolled into that. And so welcome, Dr. Autry. So happy to have you here.
Thanks, Alan. Appreciate it. Thank you. I didn't know that bio had all that old stuff in it, but I'm glad it brought up some good memories. Thanks.
Was some of that stuff not accurate? I'll just cut
No, it's accurate. I just forgot I won some of those awards.
You forgot how important you were, right?
That's what 20 years will do for you.
Yeah, I hear you. I got a few on you too, I think. So I met you at the first Tropical CE I ever went to. It was in Curacao in, I don't know, it must have been 2000. And, no, it must have been 2003 or 4, I think. And what a great time that was. And then we recently spoke in Cancun or in Riviera Maya, which was a great experience. And thanks for having me there. We're here today to learn a little bit more about you and talk a little clinical, have a little fun, get our viewers to know you. Now, you're a true Carolina girl at heart, North Carolina. You even grew up burning tobacco. Hopefully,
I did.
Not smoking it. Will you
tell us?
That's
right. I don't know how I got out of there without smoking cigarettes. My mom didn't smoke, so maybe that helped. But my father did, and of course, all my cousins and uncles. And but I somehow got out of there and finally convinced my father to stop too. So it's kind of hard when you grow up in that environment to get away from it. Yeah.
Well, you probably absorbed enough of it through your skin, barning it, right? What's a day like barning tobacco?
Yeah, so well, it was early, you know, when I was a kid, you know, most of it's done, it was done a lot by, as far as planning it, because it was done in the season we were all in school, was done by, you know, migrant workers or people around the city around the town who did barning tobacco, that sort of thing. But by the time the kids got out, like us, I mean, we were 5, 6, 7 years old, even up until I went away to college. We got up early, you know, 4 or 5 o'clock in the morning, and then we wait for kind of that first barn to start. And so you have, we are either out in the fields picking the tobacco. So you start by taking the bottom first, and then you go field to field, and you just, as the leaves mature, you take them to the barn and you put them in there, and then you cure it or heat it up for a few days. And then what is green turns brown, like what you see, of course, in the end of a cigarette. And then we take it to market. So that was just a continuous cycle of doing that. So very hot days. You do get what we call tobacco sickness, which is kind of the worst drunk you've ever had, where actually the materials and pesticides and everything kind of get into your skin, and you can actually get tobacco sickness. So we would wear these black trash bags all day long in 100-degree heat. In order to protect our skin from getting that into our skin, because you're constantly, you know, grabbing it, putting it under your arm, and then putting it into the barn. So probably, you know, exposed to a lot of things as a child that were not good for me. But that's just that's what we did. That's all I knew. And so people will say, you know, you went to pharmacy school and then you went to optometry school. Why'd you do all that? And I was like, because I didn't want to go back to that farm.
Right. Well, it's not like I don't do anything bad to my body at this age. And I remember kind of how a tobacco sickness feels the first time I ever dipped, you know, I'm sure the pesticides make it worse.
Lightheaded, everything spins. Yeah, probably similar to that. Yeah, it's but you know what? It was a very interesting upbringing because, you know, I have a work ethic that just my husband says is too much sometimes, you know, so it instills in you some values that are that you don't always see even in my children today who didn't grow up in that type of environment. And it just, you know, you get it done, you work till you get it done. Doesn't matter how hot you are, doesn't matter what time it is. You continue until, you know, the barns are done. And so for me, looking back, it was invaluable, and I don't think I would change anything about, you know, my background.
Well, you're legendary for your work ethic, and I imagine when you come from a perspective of doing hard physical labor like that, this sitting at a desk and seeing patients is, you know, is a cakewalk.
It's gravy. That's right.
Yeah, you know, you brought up your pharmacy degree, which I wanted to talk about a little bit. It's been an incredible asset as a clinician and a podium speaker, and I bet there are some non-obvious ways that it's helped you as well. What's the most non-obvious way that your pharmacy education helped you in optometry?
I think and this may be obvious, but it really got me into ophthalmology. So when I left optometry school, and one of my externships was in ophthalmology, it's actually in this office where I am today. And so it was a referral center, and I was just amazed at how quickly with the ophthalmologist that I kind of could walk the walk and talk the talk, if you would. Because the way pharmacists are trained, we're trained really on systemic diseases and the treatments for those. In optometry school, I found I had that kind of training that we really, as optometrists, we learn about the ocular side of things, but we don't always learn the true systemic, you know, down to the wire systemic disease information, like, you know, how does sarcoid really affect this, and this. And so as a pharmacist, we learn a lot more, I think, about the systemic basis of a lot of diseases that later on, you know, I find out now that had, you know, a lot of ocular associations. So it was very interesting for me to be able to talk that, you know, that way with the ophthalmologist, and I think they appreciated it, and I think that's how I got my foot in the door here.
One of the things I do when I do these interviews is I go and look at your list of lectures, and I'm particularly drawn to ones with interesting names. This next question is a two-part question. Number one, why should we listen to a Tar Heel lecture about raging Cajun red eye? Number one, and is there something about ocular response to Creole that we should know?
Well, you're going to have to call Paula Jamian about that one at Seco. Yeah, so Paul, it was in New Orleans where Seco was. I don't know if that was the year before last or last year. And
2 years ago,
he asked me so he asked me to put together a lecture kind of on a hodgepodge of red eye things, you know, anything from systemic disease causing of red eye to, you know, corneal abrasion. And so, and he wanted to call it Raging Cajun red eyes. So I can't take credit for that, but it was fun. It was a very fun lecture. And actually I've gotten asked to do that again just in the next month. So it must be sitting there on the website. Very interesting looking.
Yeah, everything's on that Arbo website, and that's great. I interviewed Paul not too long ago. I'll run them back to back. Perfect.
Okay.
Now,
That'd be great.
Another thing I noticed about your lectures is that, honestly, they can be painful, Jill. I mean, you lecture a lot on pain, you know, a topic that I don't see covered too often. How might, I had a question. I was wondering about how you might manage a patient in severe ocular pain, let's say from blunt force trauma, who is concurrently addicted to opioids.
Yeah, so one of the lectures I have does go into kind of the opioid situation and where we are with that and what we can do. So, you know, a lot of ocular disease issues, you know, probably don't require systemic therapy. I mean, let's say you have a patient with a corneal abrasion. I mean, in general, cycloplegiing that patient, putting them on a bandaged contact lens. I use a lot of what we call comfort drops, which are sort of weak anesthetic that you see a lot of the ophthalmology groups using PRK, that sort of thing. So, you know, for many corneal type things, you really have a lot of options without putting them on something that's systemic. So I try to avoid that in most cases. If not, I do a lot of, for those patients that I'm concerned about with history of abuse, I do a lot of Tylenol ibuprofen combo. That gives you a good punch. It's been likened to really about the same as a Tylenol number 3. So we can do that in short term, and anything that's longer term than that, you know, you're talking more than a few days of pain, probably should be co-managed with somebody at that point if you're talking something that's more serious. So that's kind of the way I usually approach it.
Yeah, even in the case of opioid addiction.
Yes, yeah. You got to be real careful about that. So topically, if you can, you know, don't forget your topical non-steroidal, your cycloplegia makes a big difference, and then your even OTC stuff can make a pretty good difference. So that's usually how I try to do it. Yeah.
That's great, very clear. And you lecture a lot on glaucoma, specifically MIGS. There's controversy around the benefits of MIGS in phaco alone versus phaco with MIGS, such as limited benefits in terms of IOP reduction compared to cost. But on the good side, it has the potential to reduce requirement for future glaucoma surgeries. In your opinion, is the efficacy of MIGS in phaco procedures significant enough to warrant it or to justify the cost?
Well, certainly if you have someone who's already under controlled, it certainly does, because you're already going in there anyway, and you have that opportunity. And there's different, you know, the studies are kind of variable depending on what MIGS you're talking about. So, I mean, everything from a Cahoot dual blade is going to be different than a Hydrus, is going to be different than a Zen, is going to be different than an iStent. And now we've got the ability to use 2 iStents now that we didn't have that in the past with the iStent inject. So I think if you're in there already, certainly if the patient is under control, that's a good option. I don't promise patients outer drops. What I usually want to say to the patient is, you know, we have an opportunity while we're inside the eye during cataract surgery to try to do a procedure that may help decrease your need for drops now or in the future, or maybe make the drops you have work a little better. I think when we first got into MIGS, especially iStent, we kind of thought, oh, you know, we're going to be able to tell patients they can drop their, you know, their drops and stop 1 drop, maybe if they're on 2. But I don't think that that's predictable enough. I agree with you in order to be able to say that to patients. But I do think if the patient has fairly moderate to severe glaucoma or is under controlled or is non-compliant, which of course is probably over half of our glaucoma patients, if not more, then I do think it justifies it.
And is the MIGS, do they have to go out of pocket for that?
No, most insurances will cover. Yeah, so you get some with the government, like a Medicaid, but then if they don't cover iStent, which is in Medicaid in Texas doesn't, they will cover Cahoot dual blade. So we have to sometimes look at different procedures and options for the insurance. But in general, most of the time, insurance will cover it, minus whatever deductibles and stuff they're going to pay anyway for their cataract surgery.
Ah, interesting. Yeah, that's a world that I never really, I haven't learned much about. So thanks for that. I want to move over and talk about some kind of legislative stuff in a way. Remember learning about gap junctions?
Ooh, yes.
In cells? Well,
I think
there's a few ODs out there who are gap junctions in terms of liaising with ophthalmology, and you're one of them. We know the history of the two professions, and it's been, interesting, and there's been a lot of tension over the years. Has ophthalmology's perception of, you work closely with ophthalmology and an optometric referral center, has their perception and attitude towards optometry changed in the past 5 or 10 years?
I definitely see it with the younger ophthalmologists, the ones that are, sorry, my light goes off if I don't move.
Do a little.
Maybe you can edit that out.
I'm going to leave that one in. That was good.
Yeah, my little dance there, and I see that being put on the boards where at Tropical CE. I think the ophthalmologists that are, younger, newer, out of training, tend to be a lot more open. I think they've worked in the situations where a lot of optometrists have worked with them through their training, and so they tend to be a lot more open. I do still see, it is more difficult with the more traditional ophthalmologists who are out there, but I do think it's changing. I think for the good, and I think people that are in a transition point like me, or liaison point, if you will, to some extent, is helping bridge that gap. So but with the Walt Whitleys of the world, me, Ben Gaddy, Doug DeVries, people who are in those spots where they work a lot with ophthalmology, I think it only enhances, where we will be now and in the future. And we're putting out such, well-educated students now too. I mean, they're really ready to enter the workforce, and they're really well-educated on the, the side of, more pathology than I think we've ever been before. So I think that's going to help as time goes by as well. But I saw that even in pharmacy. So when I came out of pharmacy school, I went straight into to a hospital pharmacy, and I worked really well with the younger guys, and I rounded with them, and I changed medications based on patients' renal function and their hepatic function. And they were like, yeah, dose it however you think is best. I would run the creatinine clearance on a patient. This patient only needs this drug once a day instead of twice a day. And they were very open to that. But then I would write that same, workup for an older, GP or general surgeon, whatever I was working with at the time, and they would ignore it. So, it just, I think, education is full circle.
Yeah, I think that's accurate. In Maryland, we recently went for an enhanced law that we won, and we were able to get more letters from ophthalmologists than ever, and they were all younger ophthalmologists. So I think you're on to something there. I think you're right with that.
Well, I'm sure that didn't hurt that you were probably asking for them, Alan. So maybe maybe it has to do some with
they begged
with you as well.
Please, Alan.
You don't take no for an answer, I've heard. So
please, Alan, don't do it. Let someone else do it. Now, let's talk. I want our viewers to get to know you a little personally. I know that your spare time is sparse as you're raising 2 boys. How old are they now, by the way?
Well, we'll be 16 and 15 in the next month.
Gotcha.
So they're less than 1 year apart. So again, my work ethic, get it done.
Couldn't just do twins, could you? And then you had third boy with Stu. I know that Stuart is your third child, and you're working full time, writing and lecturing. You're big on CrossFit. Have you picked up any other interest outside of optometry, or are you sticking with what you got?
Yeah, I think a lot of it comes back to optometry. I do volunteer. My kids are big into something called YMSL. It's Young Men's Service League. So there's a lot of volunteer groups out there for mothers and daughters, and there's certainly like scouting and other types of father-son type of volunteers. So I was really happy to find this group called YMSL, and it's actually mothers and sons. Oh. So we volunteer together so many hours a year, and then they volunteer on their own as well. And I do on my own as well. So, you know, I was at the food bank last week on my day off volunteering. And so it's been really good to help me kind of spend more time with the boys outside of telling them that they need to study and they need to do this and they need to do that. So we've really enjoyed that the last couple of years. It's for high school boys. So I'm, you know, halfway in now. I've got a freshman and a sophomore. So that's one thing that's really kept me pretty busy here lately. That's fantastic. I mean, it's such a key thing because, you know, when you have two boys, I have two boys, and a lot of the activities are things they're doing with their dad because they're, you know, for many people, you know, for women who don't share the same interests, and they're spending more time on those things with dad. To have that time with mom is invaluable. So I think that's a great thing. Yeah, it's been really good. So I encourage any mothers out there with sons or, you know, mostly sons to look into it. It's a great group and does kind of mesh the mothers and the sons together. So it's been really good awesome. For us. I wish I knew about that when ours were younger. They're college age now. Okay, so we're at the point in the interview where we have a couple questions for our viewers here, from our viewers. So I'm going to read them to you. Okay. The first one is, why do some people call you LG? Have you been talking to Ben Gaddy today? Not me. Yeah. So, you know, I don't know where it actually came from, but LG stands for Little General. Yeah, so it stands for Little General, and I think my husband started it for obvious reasons. You know, you can't really probably tell here, but I'm barely 5 foot tall and I weigh about 100 pounds. So but I have all this energy and I have this Napoleonic complex. I've been called a bull in a china shop and all kinds of other things. I'm sure worse things than that. But, you know, and so LG kind of somebody started it and it stuck, and now it's kind of it's all through the lecture series, and sometimes somebody will leave a note, you know, on my lecture board, like, hey, LG, you know, so it's kind of following me for good or bad. And there's another question here from another viewer. It says, where did the term small tips come from? Yeah. I'm not sure how appropriate this is, but we can cut that. Yeah, I'll cut that out. Don't go into it. We don't want it. Don't waste the time talking about it. This one will give away which viewer it is. So another viewer asked, who's the one OD Stuart isn't allowed to keep up with when drinking? Ben Gaddy. Okay, there you go. I mean, Ben Gaddy, he's a tall drink of water, man. I mean, he's got all this, you know, space to hold, you know, alcohol. He's in Kentucky. He drinks bourbon like it's, you know, milk. And so anytime those two are together, I have to limit them a little bit. The problem is they also play golf together. And so by the end of 18 and sometimes, you know, an extra 9 as they call it, or 36 holes at the end, I've spent more than once, you know, gathering those two back to the house. So that's we try to limit it. Out in the sun, not getting any water. You know, I'm small too. I'm like the size of one of Ben Gaddy's calves, and I will tell you that you know, I can hang. So we'll have to just build up Stuart's tolerance, and he'll be fine. No, I don't. You know, and the thing is, you know, a lot of these times when we're hanging out with Ben lectures with us, is, you know, you have and Wald and, you know, Paul Karpecki and all those guys, you know, and so just a great group of lecturers we have with us all the time. But, you know, Stuart's got to work too. You know, he's there trying to make sure everybody else is having a good time. So I have to make sure he doesn't have too good of a good time, or he, you know, he's not taking care of his business. I saw that in Riviera Maya. He was alone there, and I'm talking to him, and I know his mind was in a million different directions, and I don't fault him for that. I know what he was doing there. It was a great trip, which is a great segue into the end of this, where we kind of wrap it up. But I want to talk about Tropical CE. What beautiful locations do you have planned post-COVID? Yeah, so we actually are going to Mexico this summer. So it's a family trip. It's one we were supposed to do last summer that got canceled. It's at the Grand Moon Palace, which is a all-inclusive place, which you don't always see for families. I mean, it has adult sections as well, but my kids love it. It's the place that they always ask to go back to, and so we're doing that in July. And then we have, as long as we can get Europe to open up, we have Portugal set for the fall. So yeah, that's going to be a great trip. So a lot of people always do think, because it's called Tropical CE, that we only go to Mexico or those places, but we do a lot of other trips as well. I mean, we went to Alaska last summer. Great trip for us, and then we've gone to Australia. We've certainly done other places that are nice, tropical, and Tahiti and those places, but sometimes we mix it up a little bit and do Spain. We've done Italy. So those are all kind of great things that we're looking at. Next year we go to the Bahamas, to a new place. We've been to Atlantis a few times, but now we're going to a new place next time, the Bahamas. And then we do the wine country, so we do Sonoma next year as well. So we have a lot of people who a lot of ODs who come on that, do their girls trips as well, or couples. So it's Tropical CE is really, it's great education because we have great lecturers come. So a lot of the names are already listed, but so many more too. But it's also, it's sort of like, you've created this camaraderie with ODs on Facebook, which is out of this world. And we've kind of done that with Tropical CE for people who like to travel and get their CE. I mean, so many people. We have one lady who's been almost 50 times with us. And so, yeah, Jimmy Jean. Yeah. So, I mean, people come back, once you go once and you meet a few people, and then people start saying, where are you going to go next year? Where are you going to go next year? And so it's a lot of fun. And Stuart, it's more than just people, signing up for a cruise and then you never really see anybody except at the meeting. We do dinners together and we hang out by the pool together and we go snorkeling together. And so it's really, you meet a lot of good people on those trips and make a lot of good friendships. And so we like to think that it's more of a family of traveling together and getting good CE than just kind of a vacation.
The things, and you left out things like snorkeling and zip lining, and you guys know your way around these islands. You know the people, the restaurants. So it's a great way to mix learning with fun. And some things you left out, I think that you might want people to know is that you or Stuart attend each event. You make sure all the logistics are taken care of. When I got to Cancun, he was right there welcoming me, with airport transfers and any issues that arise. So it'll change your outlook on CE. I strongly recommend that you visit their website, tropicalce.com, to learn more. And you can reach out to me to get you in touch with Jill, or Jill anytime for any information you're missing on that, right? Did I get it all? Yeah, the website's great. And then, people can call me or email me. I mean, you can throw my email up there, is fine. But it's just, like I said, it's almost a turnkey kind of thing. So if you're looking and you're like, oh, I don't really know when I get there, do I take a taxi, do I not? We do the shuttles, we do the dinners, we do, a lot of things that you don't have to worry about. So if you're looking for something to get your CE, but also hang out with some cool people and, not have to worry about a lot of the details, then we'd love to have you. Yeah. And don't forget to bring me along. I will be happy to carry your bags. Anytime. Yeah. I seem to get a lot of friends around Tropical CE dates. Yeah, so everybody wants to go with me, and I've had a lot of my office staff want to be my nanny over the years. Yeah. That's awesome. Yeah. I got a picture here. This is you and Stuart and the kids. Is this on one of the Tropical CE events? Yep, that is actually at the Mexico place that we're going this summer. So it's the family event there. Friends of mine, we were supposed to do it earlier in the morning, but then they had to change it for some reason. So it was really literally about 1 o'clock in the daytime, and the sun was killing us. So someone said I should have done a Ray-Ban commercial or whatever we all have on there, because it look like we're trying to be models for the sunglasses. But what's funny about Stuart, in all of these things too that somebody mentioned, and he hangs out a lot with all these guys. Walt Whitley has me coming to his program in May in West Virginia, and he was saying something about Stuart. Somebody's like, "Who is Stuart? Who is Stuart?"
And I knew that Stuart had become very popular. I think I was at Seco one time, and it used to be, oh, I think that's Dr. Autry's husband, Stuart, whatever. But literally someone came up to me, a rep or something, and they said, and I said, I'm Jill Autry. And they said, oh, you're Stuart's wife. And I was like, yeah.
That's where you jumped the shark. He's more of an optometrist than his famous
I've been
wife.
lecturing here for 20 years, but now I'm known as Stuart's wife. So,
well, listen, that's great. That's great stuff. I'll see you there.
Story.
I'll see you. I'm going to need to get out of Dodge, once this COVID thing blows over. I'll see you at one of those. Portugal sounds really nice. And I want to give you a special thank you for taking time out of your busy day to be here. And I really would like to ask you if you would consider coming back, several months down the road and revisiting some clinical topics with us.
Oh, yeah, for sure. I'll bring you some pictures of Mexico, too. Yeah.
I want to see.
Yeah, that'd be great. And I really, Alan, I think it's been said before, but I hope how much the optometric community appreciates, what you do and where you've been with, not only the political side of things, but ODs on Facebook has been, just a breath of fresh air, for us to be able to communicate, hang out together. And this, is kind of new to me, but I watched your episode with Brian a week or so ago in his post-COVID situation. Very humbling, very, a great interview, and just something for us really to think about what's important in life and watch that. It was a very, very good piece. Appreciate that.
Well, thank you for saying that. Coming from you, someone who I admire and have a friendship with, that means extra. So again, thanks, Jill, and thanks for being here. And say hi to Stuart for me, and we'll have you back soon.
Okay, thanks, guys. Take care. Yeah,
okay,
appreciate it. Bye-bye.
Hello, everyone. My name is Keith Slayden. I'm a co-curator for Retina Rocks and practice currently at Bennett and Bloom Eye Centers in Louisville, Kentucky. Here at Retina Rocks, we just wanted to give you guys a case once a month just to kind of challenge you and keep you on your toes. Today's case involves major vision problems for a new mom. This patient presented to clinic with vision of counting fingers bilaterally. She was diagnosed with toxemia of pregnancy, otherwise known as preeclampsia, before delivery, with rapid bilateral vision loss and severely elevated blood pressure. We examined her in our clinic 10 days postpartum. Anterior segment findings were completely unremarkable. Fundus examination showed multiple patches of creamy white ischemic RPE and outer retina scattered throughout both posterior poles. At Retina Rocks, we heavily stress knowing the anatomy of an OCT scan so we can adequately describe what is being affected and appropriately diagnose the pathology. OCT scanning showed normal inner retinal bands extending from the internal limiting membrane to the inner nuclear layer, marked by the red arrows. But the photoreceptor layers showed multiple additional hypo and hyperreflective bands, outer retinal disorganization, retinal edema, thickened RPE, which is marked by the yellow arrows, and RPE loss with visible Brooks membrane, which is marked with the orange arrow. Toxemia causes choroidal ischemia with secondary RPE dysfunction, which can cause exudative retinal detachments. Outer retinal ischemia causes these bizarre and pathognomonic OCT changes. 1 month later, our patient's vision remarkably improved to 20/25 bilaterally. The creamy multifocal lesions resolved with residual pigmentary changes. The prior OCT outer retinal changes resolved with residual outer retinal and RPE atrophy. Preeclampsia, which usually develops in the third trimester, manifests as severe hypertension, swelling of the legs, feet, and hands, and proteinuria. When seizures develop, the condition is called eclampsia. This may lead to serious and possibly fatal effects for both the mother and the child. Patients may develop hypertensive retinopathy as well. Choroidal ischemia can cause infarction of the RPE with exudative and hemorrhagic retinal detachment. These changes usually rapidly resolve with delivery, although they can cause chorioretinal changes mimicking macular and retinal dystrophies. So what are the key things that you should take from this case? Number one, If you examine someone who is pregnant with these creamy lesions or severe hemorrhaging in their eyes, make sure to check their blood pressure and either connect with their OBGYN or send the patient to the ER. Number 2, these lesions resolve once the blood pressure is under control, and if treated properly, they will maintain relatively normal vision. Number 3, if you see someone in their 50s plus with weird pattern-like dystrophy changes, ask if they had a history of preeclampsia. It could explain the appearance of their abnormal retina. Thanks for tuning in. We will see you all next month. Please visit our website, www.retinarocks.org, for more information, and follow us on Instagram at retinarocks, retina.rocks. Thanks. Bye.
Hello, and welcome to this week's Fluorescene Eye Care Industry News. This week in Retina News, Endogena Therapeutics announced that the U.S. Food and Drug Administration has granted orphan drug designation for its EA2353 ophthalmic suspension targeting retinitis pigmentosa. EA2353 is the first small molecule being developed for endogenous photoreceptor regeneration, with clinical trials anticipated to start by the end of the year. The treatment works by selective regulation of the endogenous adult stem and progenitor cells for controlled tissue repair. This approach is gene-independent, which has significant advantages in inherited retina diseases that have multiple genetic causes. In more retina news, Bausch Lomb announced new data from the National Eye Institute 10-year follow-on study results of the AREDS2, which reaffirms the clinical outcomes of the AREDS2. Based on this data, the NEI continues to recommend a specific nutrient formula to help reduce the risk of progression in patients with moderate to advanced age-related macular degeneration. The study results were presented at this year's ARVO meeting. The NEI's 10-year follow-on study with the AREDS2 analysis included 3,887 people, 6,360 eyes, with intermediate to advanced AMD over a 10-year period. The study further validated the original findings about AREDS2 formulation with 80 milligrams of zinc and provided support for the continued benefit of lutein and zeaxanthine, which were shown to have an incremental beneficial effect as compared to beta-carotene. In corneal crosslinking news, investigators evaluated the effects of sodium iodide on riboflavin concentration in corneal stroma before and during ultraviolet A light exposure using a novel transepithelial corneal collagen crosslinking procedure. They concluded that the addition of sodium iodide to riboflavin solution is associated with increased riboflavin concentration in corneal stroma throughout a clinically relevant time course of UVA exposure. This effect may be a combination of enhanced epithelial penetration and reduced riboflavin photodegradation and should enhance intrastromal crosslinking. In dry eye and uveitis news, Oculis, a late-stage biopharmaceutical company, announced positive data from 2 clinical proof-of-concept phase 2 trials with OCS-2, its novel topical anti-TNF alpha antibody fragment candidate in dry eye disease and acute anterior uveitis. The data were presented for the first time at ARVO. The phase 2 multi-center randomized vehicle-controlled double-masked prospective study, OCS-2, was found to be significantly more effective than vehicle in relieving severe ocular discomfort associated with dry eye disease. A pre-specified exploratory pharmacogenetics analysis demonstrated a statistically significant association between response to OCS-2 in patients with dry eye disease and a genetic biomarker. Additional studies are needed to better understand the role of unique gene variants in dry eye disease and susceptibility to anti-TNF alpha therapies. For OCS2 and uveitis, a phase 2 multicenter randomized parallel group double-masked active controlled study of patients with acute anterior uveitis, the administration of OCS2 demonstrated efficacy in accordance with the pre-specified criteria in resolving ocular inflammation. OCS2 was well tolerated without steroid-type side effects or eye irritation. In more dry eye news, an experimental varenicline nasal spray can reduce signs and symptoms of dry eye disease. The results of a phase 3 trial suggest Oyster Point's OC1 works by stimulating the trigeminal nerve through the nasal passage, causing the eyes to tear. OC1 also improves symptoms relatively fast in as few as 14 days. Marketed as the oral drug Chantix by Pfizer, varenicline is prescribed to reduce cigarette cravings. Administered as a nasal spray for dry eye, much less of it ends up in the bloodstream. In myopia control news, Johnson & Johnson Vision announced that the FDA approved Acuvue Abiliti Overnight orthokeratology contact lenses designed to help manage myopia. According to the release, clinical studies showed Abiliti Overnight to be safe and effective with an average reduction in axial elongation by 0.28 millimeters over a 2-year period. A design for astigmatism is also available. In fake eye exam news, yes, you heard me right, a Kenosha County eyeglass salesman faces criminal charges for impersonating an eye doctor. In the fall of 2019, the patient went to Next Day Glasses in Paddock Lake, where she says Hagopian advertised eye exams. She says he invited her into a small room within the store, examined her eyes on an optical machine, told her she needed a stronger prescription, then sent her home with a pair of trial contact lenses. It wasn't until that night she discovered the trial contacts had been expired for 8 years. The mother of 7 filed complaints with state regulators, her state representative, and Kenosha Sheriff's Office. The patient claims Hagopian performed an illegal eye exam, sent her home with expired contacts, and coached her to treat an eye injury, all without a license. Hagopian was charged with practicing optometry without a license, misdemeanor theft, and obstructing an officer. This may be the first time someone has been criminally charged in Wisconsin for posing as an eye doctor. In gene therapy news, Applied Genetic Technologies Corp, a biotechnology company conducting human clinical trials of adeno-associated virus-based gene therapies for the treatment of rare retinal diseases, has reported additional positive data from the ongoing X-linked retinitis pigmentosa phase 1 and 2 clinical trial. Data from this study add to the body of evidence suggesting that durable improvements in visual sensitivity and visual acuity may be achieved in patients receiving AGTC's XLRP product candidate, while continuing to demonstrate a favorable safety profile. Going forward, AGTC said it expects to present 12-month trial results from the ongoing Phase 1 and 2 clinical trial at the American Academy of Ophthalmology annual meeting in November. In low vision news and macular degeneration news, the American Macular Degeneration Foundation is supporting the next phase of clinical testing of corneal photovitrification, a new corneal laser procedure for vision improvement in patients with late-stage, dry or wet age-related macular degeneration and other retinal disorders. Previous clinical studies have shown the painless procedure allows patients to regain several lines of useful vision to read again and to experience improved quality of life. The procedure, which takes only seconds, uses a low-energy laser to minimally alter the shape of the cornea, bending light rays differently and relocating them to an area just outside of an AMD patient's damaged macula. Patients report instantly improved sight, and the brain continues to adapt this new information source, allowing vision to improve in subsequent years. In many cases, there have been no adverse reactions, complications, or patient reports of discomfort during or following the procedure. CPV can be used for low vision patients with central vision loss whose best corrected visual acuity is between 20/60 and 2800, including those with Best's disease and Stargardt disease. It can also augment the effectiveness of assistive devices such as magnifiers or newer head-mounted technology. CPV may also hold vision-restoring potential for those with macular holes that were unsuccessfully repaired with prior surgery and patients with reduced central vision from macular scars. Future applications include diabetic macular edema and myopic macular degeneration. Now, that's all for today's news. Enjoy the rest of the Fluorescene show.
Dr. Art Epstein, a native New Yorker now residing in Phoenix, Arizona. Dr. Epstein graduated from the City College of New York with a BS in psychology and received an OD degree from the SUNY College of Optometry, where he also served as the college's first ever resident in ocular disease. Dr. Epstein is well known for developing one of the most successful dry eye specialty practices in the country, the Dry Eye Center of Arizona. He heads the practice's Ocular Surface Disease Center and serves as its Director of Clinical Research. He's a fellow of the British Contact Lens Association, a distinguished practitioner of the National Academies of Practice, a fellow of the American Academy of Optometry, and a diplomat of the American Board of Certification in Medical Optometry, and founded and currently serves as president of the American Board of Clinical Optometry. Listed by Optometric Management as among the most influential in optometry, Dr. Epstein is a prolific author and lecturer who's published many hundreds of articles, scientific papers and book chapters, and presented well over 1,000 invited lectures. He's a contributing editor for Review of Optometry and executive editor of Review of Cornea and Contact Lenses. He founded and serves as chief medical editor of Optometric Physician, the first e-journal in optometry. Dr. Epstein is also a reviewer for numerous clinical and scientific journals. Dr. Epstein was recently appointed to the prestigious Dry Eye Workshop, DEWS 2. Active in the profession, Dr. Epstein is a past chair in of the Contact Lens and Cornea section of the American Optometric Association. He led and was a primary strategist of the AOA's response to the international fusarium keratitis outbreak and was frequently quoted in news media throughout the world, including an appearance on Good Morning America. He serves on the U.S. National Committee for Worldwide Eye Care Organization Optometry Giving Sight. Wow, that is some resume. Welcome, Art.
Thank you, Alan. Actually, some of it's a little old, which is good, because if I was still doing it, I'd probably be dead of exhaustion. But what's interesting is when you hear your own accomplishments, the things that that you've done, it sometimes is almost shocking. That you say, how did I manage to do all that? And people always say, oh, you must be so busy, you must be so busy. And I think now, because of COVID, for the first time in my life, I am that busy. I always say, no, I'm really not that busy. I have plenty of time. I could talk to you, whatever. But normally, I try not. I guess I don't like believing my own PR, I guess, is a good way of putting it.
Well, you did, and I did it. And if you really like it, then every Monday we could schedule and just put some money in my Venmo account, and I'll read it to you again and again, just to kind of, remind you.
It sounds good. You did an amazing job, by the way. I have to tell you, normally I get tongue tied if I have to introduce myself after like the second paragraph, and he's a member of the. But very nice, very nice.
Speed reader. That's I took those classes, but I wanted to start the interview by saying normally my interview style is highly interpersonal, and I think anybody who watches them knows that. I like people to get to know a lot about the people I'm interviewing, but after listening to your recent interview by Scott Jens on his podcast, I think it's called Sandbox Stories, right? You really laid it bare. I mean, it was an incredible story, and I thought it'd be better to take a different route. Just to briefly rehash, Art has a compelling story. He went through some really challenging life experiences early on, and I don't want to be repetitive, and I'd love to help Scott get some listeners to that show. So I encourage anyone that wants to hear your story of struggle and success to listen to Scott Jens' podcast, Sandbox Stories. In any event, we'll get things going today within your particular area of clinical expertise. You think you can handle that?
I don't know. The sad part is, I sometimes laugh, like, people say, oh, you should never take it home with you. I literally found my calling with dry eye and ocular surface disease. So, I think about it. I'll wake up in the middle of the night actually thinking about it. It's like unraveling the great mysteries of Genesis itself. We've made so much progress over the last year or so, in part because of COVID and the complexity of patients, and our understanding is, just exploded. It's almost exponential. So, yeah, actually, I could probably spend the rest of my life talking about dry eye.
Great. We'll hit up a couple of questions. Some things I wondered about, and some things I read about that you had said. Some real great things that you shared insight, and off the cuff, especially the dream study is. I think you're referring when you say that things in the past, 1, maybe 2 years that have changed. One of them is the DREAM study, which tested the validity of omega-3s as a solution to occasional dry eye, I think it was. And the conclusion, which nobody's really sure what that was, it was skewed kind of by the media, was that omega-3s do not benefit dry eye significantly. And some people agreed with the conclusions. Others pushed back, saying there were flaws in the study design, like I think inclusion criteria was too low, and critique the choice of olive oil as a placebo. What's your take?
Yeah, it was an interesting study. A lot of my friends were involved in it. Penny Asbell was the lead investigator, and I think she's absolutely wonderful. And it's just the study. The study really didn't provide the insight that everyone was waiting for. We thought it was going to be a blockbuster study, validate a lot of our clinical experience, and the conclusions were that although both olive oil and the omega-3 they used, which was a decent omega-3, really helped dry eye patients, but there was no real statistical difference. But some of these NIH studies become almost PR circuses, and published in the New England Journal of Medicine, and they have big press conference afterwards. A lot of it made no sense to me whatsoever, because I've had phenomenally good experiences with omega-3s once I figured out what was working and what wasn't. The formula is actually very simple. It has to be in a triglyceride form, which they used, because ethyl esters, which are the easier form to produce, the less expensive form, are just not absorbable. Humans don't absorb ethyl esters very, very well. So you get relatively little concentration of active ingredients, if you will, in the bloodstream. And it needs to have, at least from my take on the study, higher EPA to DHA ratio than they use. They use a 2-to-1, which is pretty standard. It piqued my curiosity, so we actually did a study. I was able to get my hands on pure EPA. So there's a company that was able to formulate a triglyceride-based pure EPA formula, and we took patients that were currently on PRN, I think it was DE at the time, which is a great product. I use it all the time. I use DE3 now, and I think as a commercial product, it's for us it works extremely well. We had 20 patients in this pilot study. 18 of them did not want to go back on a PRN. They had such profound improvement in signs and symptoms, and virtually all of the metrics that we use to assess dry eye and non-invasive breakup time, lipid layer thickness, interferometry, OSDI, everything was off the charts in favor of the additional, or I should say the EPA formulation. Problem is it was extremely expensive to make and not commercially viable, certainly not for us. But I'm convinced that the DREAM study kind of missed the target by ignoring some of the details and nuances and understanding how omega-3s work in actually providing the raw materials that meibomian glands need to create meibum. So you don't give, it's like a coal stove. You don't give a coal stove coal. It could be a beautiful looking stove, but you're going to freeze to death.
Yeah. Which is a good segue into the next dry eye topic, although they're similar. You talk a lot about the state of the whole body now, as opposed to just thinking of inflammation as the cause of dry eye, and a couple of the things that I saw you wrote and talking about. And this has a lot to do with recent research into the human microbiome, which also caused us to look deeper into the ocular microbiome and the contribution of the gut microbiome to what now might be secondary, the inflammation. Maybe Western style diseases, I think people refer to, and how they all relate. As far as I think you either coined the term or used the term altered immunity and gut microbiome. What's happening in this area that can be applied to our viewers' dry eye knowledge and treatments now?
It's a great question. So I look at it like this: in 50 years, we'll look back on what we're doing today and what we know today, and we'll go like, God, we didn't know anything. I remember when I was a little kid, I visited my mom, or I met my mom, I should say. She was coming home from work, and sometimes when she went shopping, I'd meet up with her and just spend time with her. And we were in the local butcher shop, great place to be sick. And I said, Mom, I'm not feeling well. I was a little kid, and she did the typical mom thing. She checked my forehead and she said, "Oh, you're burning up." And luckily, our GP was in the apartment building, across the street over, and Dr. Rosenstein, brought me by the window, and he looked at me, and and he said, He said, "I'll be right back." And he comes back with a medical textbook. It was probably about this thick. I mean, it was a little, was certainly not a thick textbook, but it had color plates in it. And he says, "Yep." He said, "If you have German measles," he identified it using, the color plate. I guess he was a little rusty on German measles. Maybe he was used to regular measles.
I think he was a little rusty on medicine if you had to pull out a textbook.
He was good. Every time I saw him, boom, shot, in the rear end. And I told my mom it was better immediately thereafter. I didn't want to go back for another one.
Right.
But at any rate, I years and years later, I found I made a mental note of the medical text. I forgot the name of it now, but I was in Florida on vacation and I found the medical text. But now it was about this thick. And in fact, I think I gave Delta baggage handler a hernia because I had packed it in my bags. And I realized that medicine had advanced tremendously. We're now at the point where we're beginning to understand the interactivity of all of the systems. So the eye is not something that stands alone outside of the body. It's very much part of the body. I mean, my main focus has really been local microbiome, because that certainly shifts in dry eye and in meibomian gland dysfunction, as well as, homeostasis, which we can probably talk about for hours, which is really Kelly Nichols' brilliant innovation in thinking, which was introduced at DUCE 2 in the new definition. So, in terms of, understanding microbiome, and I think, for the purpose of the conversation, staph bacteria are present all over our skin because that's what they do. They're present on our lids. That's normal. In fact, they're called normal flora. Among the things that they do is they grow, and the body controls how many can exist in a given area. But when things go awry, we end up with more staph than we normally would have. And of course, staph produce toxins to keep invading species away, which is why they're called normal flora. Those toxins, unfortunately, are very sensitizing to us. So many of us get red eyes and irritation because of excessive amounts of staph exotoxin. And in addition, all bacteria produce digestive enzymes because that's kind of what their job is, to infect, and they need to break down barriers. And they have these enzymes that they elaborate to do that. Lipase, unfortunately, happens to break down the structural element that keeps the tear film together, the lipid, and mixes with salt, in the eyes environment, and as we blink, we churn it up, creating soaps, and the soap further breaks down the lipids. So, we have a situation where we're sowing the seeds of the destruction of our own tear film because of a alteration in normal flora. So and most people don't realize that, and that's one of the reasons why hypochlorous acid has become popular, because it kind of short circuits that process.
That's interesting, because my understanding is also, and this kind of confirms that in a way, is that Demodex themselves don't create problems in the eyes. It's when they die and they implode, and you get the bacterial and rickettsial and viral proteins that the eye responds to. That's really where the dry eye side of Demodex irritation comes from. So I can see, that imbalance, maybe there's something there to kind of prove that, who knows, but fascinating. Yeah. Fascinating stuff.
And we have two of our colleagues, the Zieglers, have, a big presence on Facebook with a dry eye group, and they also provide a lot of products. They're very much focused on holistic aspects of dry eye care and overall body inflammation. So we have an altered state in terms of the body, and we see more inflammation than we ever have before. With patients, come in and they have, arthropathies, non-specific inflammation. Patients come in and say, "Oh yeah, my SED rate's high, or I have inflammatory markers all over the, over the top. They can't figure out what's wrong with me." And then you look at their eyes, and their eyes are all messed up. Inflammation is probably the best example of a non-discriminatory process. It doesn't care what the hell it attacks. You can have rheumatoid arthritis and really have almost no joint issues, and just decimates your eye. The ocular surface can be destroyed. And then we have to deal with the fallout of inflammation locally from a systemic problem, and probably a lot of that has to do with diet and things that we just barely are scratching the surface on now.
Yeah, non-specific immunity. It's going to attack whatever it attacks. That's interesting. Well, we could talk about dry eye for a whole show, so I'm going to move on to some other topics, but would you come back and talk about dry eye with us in a couple months?
Sure. In fact, not only will I come back, but I'll promise you that what I'll know in a few months will be a lot more than what I know. I literally know more today than I knew 3 weeks ago. I come into the office every day. We have a new associate. He's a great kid, Ohio State. Go Buckeyes, or Buck, whatever those things are, and Cincinnati eye resident, just phenomenal. In fact,
give him a plug.
Corey Lappin,
Okay,
just brilliant,
awesome.
brilliant young guy. And so we talk all the time, and he's pretty much like a younger version of me. So he's really interested in all the, this esoteric science and minutia. And I came in, we were talking about bandage contact lenses the other day, and we had some interesting cures from using a bandage lens, that you wouldn't expect. Normally you think of it as a Band-Aid, it doesn't cure anything. In this case, it does. And I think I was dreaming or taking a shower or something, and I had this epiphany, and I go, it's an artificial environmental barrier. That's what we've been missing. It's not just a bandage. It creates an artificial environmental barrier. So I came in, and the takeaway, by the way, was that it's replacing a natural environmental barrier, because that's what the tear film actually is. It's one of its main functions. Right. So I come in and, Corey, take a note, get ready, calling all ships, bandage lenses are artificial environmental barriers. And he goes, yeah, that makes perfect sense. So, I never really thought of it that way. So I promise when I come back, I'll have even more, non sequiturs and crazy stuff.
And maybe an invention or two, it sounds like. That's great.
Yeah, maybe. No, we have inventions. We keep them under the radar.
So I got some organizational and political topics that I'd like to cover. This year in February, I think it was, an optometry challenged an organization known as the National Association of Optometrists and Opticians, I think it's called, a group that purports to represent both professions, while it actually represents the interests of some big corporate commercial employers. And you were quoted in the article, and it sounds like this thing is quite a scam. What do you see happening with this?
It's interesting. There's been so much stuff going on under the surface that most optometrists are oblivious to. I'm sure you've heard as many times as I have, optometry is its own worst enemy. One of the reasons why is we just don't pay attention to what goes on around us. So, we have corporate, friends that have helped optometry over the years. And, I think those relationships are wonderful, but we sometimes forget that they watch out for their own interests, and sometimes those interests diverge from our interests. So what the AOA discovered is that this organization, which has been a thorn in the side of organized optometry, both nationally and locally for quite some time, has been sponsored by a number of the, vendors, corporate citizens that work closely with optometry, either, by owning large commercial chains or, in some cases, vision care insurance programs and the like. And all of a sudden, they go from just trying to deep six local initiatives, that might protect patients. For example, we're seeing a massive increase in interest in over the air, or I shouldn't say over the air, online refraction and online examinations. And again, the line between the two is blurred intentionally, which is unfortunate. And essentially what happened is there was a combination of forces of more traditional, brick and mortar providers of low-cost eye care that wanted to be able to better or more effectively utilize optometric care, more inexpensively utilize optometric care, and attend to other wish list items for these commercial providers, along with the 1-800 contact lenses that wanted to be able to circumvent optometry completely in terms of refilling prescriptions and things like that. And suddenly, this thorn in the side had become a major issue. To the point where, everyone began looking at it. I began looking into it, and it turns out it's a one-man show, a guy who apparently had some legal education, but was censured by, I think it was the state of Ohio, for practicing law without being admitted to the bar. And he had worked with lens crafters, if I remember correctly, for quite some time, as eventually working his way up to a VP level role in managing political issues for them. And he went off and created that organization, that phony sham organization. And then they'd show up at state meetings and things and say that they represent optometry, trying to create the impression that optometry was divided on a subject where we clearly weren't divided. We were very much in line in terms of patient protection. So the AOA really took the lead on that, and I think we underestimate how important the AOA is for the future of the profession and the safety of our patients. And I just was fortunate enough to, see similar stuff. So I was able to, highlight it in an editorial in Optometric Physician. But most of the credit for that, I think the AOA filed a complaint, I think with the IRS, if I remember correctly. It was a while ago, a couple months ago. And I think certainly that's been, the hidden agenda has been revealed, and a lot of the sponsors have left. They basically dropped support for that organization. So all's well that ends well, and it looks like it's going to end well.
Yeah, that's a fascinating story. We were talking about big retailers, and I had a question actually for you about Warby Parker and how its original model, they've morphed it into a brick and mortar model. I find that really fascinating. And I was always wondering, and this is just an opinion, do you think this was planned, or did their original model fail, or was the online thing a loss leader while they tried to, create this new behemoth out there?
That's a great question, Alan. I think they weren't quite first in, but they came up with a modification of, existing ideas. If you go back to the first online sellers, it was contact lenses. And in fact, I was joking with Shannon the other day that when CompuServe was, roaming the airwaves, the internet, the interwebs, they had a little store. Maybe it was The Source. I don't remember. It was CompuServe. I think it was CompuServe. And I said to my partner back then, this was 20, 25 years ago. It was maybe 30 years ago. I said, we should sell replacement contact lenses online. That's going to be a big thing. And he said, well, yeah, sounds like a good idea. And they sent me the package to open up a storefront for contact lens sales. And they wanted like $2,000, which 30 years ago was, we just started out in practice. It was a lot of money. So I stuck it under the desk thinking, I'll think about it. And I never got to it. So I said to Shannon, I said, we could have been billionaires today and had the kingdom of all online contact lens sales if I had only known. But that was really the beginning of it. What Warby Parker did is they kind of leveraged that online, progressive embracing of purchasing, away from brick and mortar initially, make it easy, came up with a little technology to make it, I think, more palpable to the customer. And then they recognized a significant rise in consumerism along with, a change in demographics. And one of their, I think, great ideas is that for every pair of eyeglasses they sold, they, give make a charitable contribution, which made a lot of, folks who were socially conscious feel much more comfortable about making purchases, maybe taking that risk. Because as you and I think both are, would agree on. I think all of us would agree that I think most patients like seeing a doctor. They like having that personal contact. A sense of that professional oversight of things. So people jumped on board. I think it's hard to say for sure what motivated the brick and mortar, but I think they realized that they couldn't do as much as they wanted to. They couldn't control the whole world without the need for optometry. And then they began to realize that optometry really needed to exist within a fixed place. If I remember correctly, I think Warby Parker also was one of the first to introduce this, robotic refracting unit. I forgot the name of it, but some company had come up with something that would refract beyond an auto refractor, and they had validated it. In fact, they used a PhD at SUNY to validate it, which was to me crazy. Like why SUNY would do that sponsored research, right. And then ultimately they said, hey, there's money in this brick and mortar business, contrary to everybody else, which was moving more to online. And I think that they essentially came in the back door of brick and mortar eye care practice versus the more traditional lens crafters and things like that came in by commercializing what was then mom and pop shop optometry.
No, they really did some really interesting things, sending frames home with people. Now they're in a place where they're creating jobs and opportunities for young ODs. So I don't, you know, the fact that it happened, no matter how it happened, I think to some degree is a good thing, because another article I read, it talks about how it suggests there are more than enough ODs to fill increased needs for the foreseeable future. And you point out in the article that in 2006, 6 new optometry schools opened and 3 more are slated to open. And then in another one of the I think it was an off the cuff, that you talked about new optometry schools opening up, even though applications and interest have been on a steady decline for a while. You mentioned the Niswonger School, which I think is in Tennessee. And I'm just going to read this because it's a quote, and I want you to address it. I've got a few more points to make before, though. But you said, however, if Niswonger is allowed to open, shouldn't we be eliminating or cutting back older programs that cause more harm than good by creating more ODs despite shrinking need? And my question, as devil's advocate, and let me preface it by reminding our listeners, there's no question that you're someone who's committed to excellence in optometric education, and we all agree one answer to graduating better ODs is raising admission standards. But can you, two-part question, can you define cutting back older programs? And number 2, how does one determine what qualifies as an area of legitimate need for a school? Because the location of an optometry school isn't necessarily correlated with graduating rural ODs. They can leave and practice wherever they want, right?
Yep, that's true. It's a sticky wicket. You know, it's a very, very challenging and difficult question. You know, and it's difficult because it's also time related. If we use dentistry as a model, when dentistry began to commercialize, you know, we're talking about the 1970s, they closed schools. You know, what they did is they increased demand for dentists by reducing the production of dental students. And some of the major programs closed. It was one in New York, not NY, I think maybe NYU. And there was another major program that closed. And what ended up happening is commercial dentistry essentially died because they couldn't afford the salaries because there was so few, you know, supply and demand. In optometry, we never had that issue. Optometry has steadily increased schools' presence based on projected demand for optometrists. And I think for a long time, it kept pace with need. There's a lot to be said for producing more optometrists because there is strength in number. And the more numbers we have, you know, especially those that support political organizations, you know, like the AOA, you know, that theoretically should make the profession stronger as we continue to expand our scope and, you know, take on greater responsibility. But I think we're reaching a point where you have to wonder, is education becoming a means to its own end, which is getting students who pay, at this point, significant amounts of money for an education and come out into a environment where opportunity for employment it becomes more and more competitive, and perhaps salaries start to go down. You know, so there's a fine point. Now, some of the older programs are functioning as older programs. I know there's a lot of innovation going on right now, is certainly being talked about in some of the schools. And I'm not talking about just the new schools. I'm talking about, you know, existing schools that have been around for many, many years. You know, New England is a great example, or New England College of Optometry with Howard Purcell, you know, forward thinking. You know, I absolutely love that guy. You know, he bleeds, you know, optometry, you know, blood, you know, it's
Yep, good friend and
his
Echo
blood.
93
I
right
was
here.
just going to say, yeah, no, I know you're an alumnus and on the board. You know, I'm a what's the word? I'm an honorary. I've made myself an honorary alumnus because I like Howard so much, and he's so forward thinking. You know, they're doing a lot of innovative things, you know, in that program. But I know that there are programs that have been around for a long time where, you know, there's just not a lot of innovation, and in fact, the class sizes are beginning to diminish because they just can't fill them. there's not enough demand because we've not really done a good job at promoting optometry, and that it creates a downward spiral of qualification. So the candidates, the candidate pool is diminishing, and some, the quality likewise can go down. Now, as I just mentioned, Corey Lappin is one of the brightest people I know, and he just got out of Ohio State a couple of years ago. This guy's brilliant, and he chose optometry intentionally. So we are producing some really qualified, excellent optometrists. Whether you're excellent and qualified or not makes no difference. We have an obligation in the field to educate you and support you and to make you the best that you can be. So, I don't want any of your listeners to think that I'm saying, oh, we're producing a bunch of bad optometrists and good luck, it doesn't matter. You're an optometrist. We have to make sure that you're practicing to the fullest extent of your training and your licensure. And I think all of us that have been in the field need to do that as well. But when you have schools like Niswanger, which I think has kind of fallen by the wayside because of COVID. I think they put it on hold. But another school has opened up. There are some very, very forward-thinking people that are opening new schools, and the new schools are modeled after next generation optometry. They're not looking to produce traditional optometrists that are heavily in behavioral vision or developmental vision or even contact lenses. They're looking to produce essentially optometric physicians who are very medically trained and medically focused. And the question and the question is that actually filling a need or being anticipatory of a need as more traditional optometry becomes more challenging? Is traditional refractive optometry slowly going away because we're seeing incursion from online and commercial interests? So, so maybe the new schools aren't such a bad thing. Maybe they'll push the older schools to begin to look at innovative educational programs. I want to say just one thing that, I think is very striking. COVID has been a lesson for all of us. Certainly you've figured it out and leveraged, the isolation and the need to be online. I certainly have. I've come up with my dry eye masterclass. I reach 2,000 people, which I couldn't do in a physical location, at a time. The last one I did was 1,200 people a few weeks ago. So, education. Imagine if you had a school and you could bring in experts from around the country, a Murray Fingerette, and I won't go through a whole bunch of names where, people are outstanding in specific areas, and you can actually have them virtually in a hybrid program. How much better it would be for all of the schools. And, the same thing with education today, where people say, oh, we have to get back to in-person education. Believe me, I miss my friends. I love seeing you walking, down the hallways at, SECO and meetings. But when it comes to education, there's a lot to be said for virtual education. It's time we open our minds and I think, went to a more hybrid model and accepted as equivalent to in-person education. Anyway, that's a lot I covered.
Yeah. You said one thing that was fascinating to me about closing down the schools. Who's this person or organization who could just demand that a school closes down?
Oh, I'm trying to make up a name. I'm racking my brain to make up a name. It's an interesting question. I don't think anybody, should be able to do that. I'm a human rights advocate. I think people should have self-determination as long as they don't hurt other people in the process. But I think if you look at how the schools are governed and accreditation and things like that, I could see setting up a commission that looks at need and says, hey, maybe we don't need 2 schools in Boston. Maybe, and again, to your point, you're 100% right. You can have 2 schools in Boston, close everything else down. The people in Boston will go find work elsewhere. We actually do have airplanes. We can actually still get on them with masks, but people travel, and that's a whole other issue. Licensure is still back, in the early 1900s. Brian Rosenblatt, who you had on, that was just a wonderful, wonderful interview, and he's taking the national boards again so he can practice in Florida. Here's one of the best clinicians, most experienced guys I know. He has to take a national board to practice in Florida. They should be happy to have him.
He's gone through on top of everything else.
Isn't it crazy? It's just crazy to me. It just makes no sense at all.
Well, that state, you know, it's an outlier when it comes to that stuff. Unbelievable. Well, you know, I think were you trying to think of ASCO, the Association of Schools and Colleges of Optometry? Yeah. So
ASCO.
You wrote, I want to move on a little bit. You wrote about in optometry's early days, the vast majority, this was your opinion, of eyeglass fitting was to correct for presbyopia. And I think you were intimating that presbyopia can be credited somewhat with giving optometry its start, and surmising that the new class of presbyopia correcting drops may give optometry a boost in the future, kind of like a coming full circle moment for us. And there are a number of drugs that are being developed that are advertising themselves as presbyopia treatments. And there's a lot of like hoo-ha over the space right now. I was initially excited when I heard about it until I learned that they were just specially for, right now, the first classes, just specially for miotics. I'm concerned the companies that are involved are overstating what the drops are, using terms like presbyopia reversal and presbyopia treatment when they appear to be nothing more than just temporary depth of focus enhancing, possibly nighttime vision difficulty inducing drops. Wouldn't a true presbyopia treatment need to act on the lens, maybe cleaving the disulfide bonds between the crystallines, something like that?
Disulfide bonds. So now you're talking my language. That's that's sexy talk. That's sexy talk.
I'm getting all molecule on you.
We're getting molecular. That's exciting. You know, it's actually funny. I don't know, 15 years ago, there was an ophthalmologist who came out with a procedure for reversing presbyopia. He basically put in stents, I finally saw. Yeah. I mean, it was ugly surgery. In fact, it wasn't done in the U.S. And I finally saw a patient who came in who had dry eye, and I'm examining this guy, and I see these bizarre things that I had never seen before. And I'm looking at them, and I said, because he hadn't mentioned, I said, "Have you had surgery?" And he said, "Oh, yes, I did. I had surgery for nearsightedness, presbyopia." So I said, this was a while ago, and he goes, "Yeah," and one of them was partially extruded. It was a bit of a mess. I called in Lappin to take a look, because again, it's a once in a lifetime thing at this point, because many of those patients, I think, are slowly aging away. But it was a disaster. It didn't work at all. I mean, this failed. And, they did it in the Cayman Islands and in Barbuda and things like that. They would have the patient travel down. But to answer your question, I'll share an interesting observation. I examined my father only once, as an optometry student and as an optometrist. I just never examined him, and he didn't go to anyone else. He didn't. I mean, my dad didn't like doctors very much, and you're probably wondering how that could be, because someone, who is my father's age would probably need reading glasses, right? So he'd have to go to see somebody. He never wore reading glasses. My father had 1.5 millimeter pupils. I've never seen anybody like it in my entire life. I don't really know why. But he was able to read, till the day he died without reading glasses, and he had, 20/20 distance. So there's a lot to be said for meiosis. It does occur naturally. Some of the miotics are actually quite advanced. Some of them are pretty much, pilocarpine, incarnate. Some are actually combination products. Visus has a really interesting, miotic, which I think may be a game changer. And we also have Novartis actually has a lens modifying medication that's in clinical trials at this point. I think it's coming. To your point, I think some of them are not going to be successful. I think the problems associated with them will probably outweigh the benefits, and the market will prove it. The good news for optometry is, if we look at it, as store readers, when they first came in, everyone said, "Oh my God, that's the end of optometry. People just go try on the different readers." We shouldn't. We really should look at it. The patients will need prescriptions. The patients will need to come in. It will reinforce the fact that we're primary providers of eye care. We're there not just for that, but also for red eyes and things of that sort. And I don't see, certainly in my practice, it's not going to become I think, a major factor, but I do think it's going to become something that we can leverage to increase our reach to a population that would typically, go just buy a pair of readers. So, yeah. I certainly don't see it as all bad.
It's funny, like we got to talk about this for a second, because presbyopia was the thing I studied diligently in the early 2000s. I actually invented an accommodating IOL, and I was at several ophthalmology academic conferences, and the guy you're talking about, I think, is Shachar.
Yes, that's
right.
So
he actually based his treatment on, he didn't believe Helmholtz was right. He had an alternate theory of how the eye accommodates, and instead of the ciliary body contracting, he thought it expanded. And he demonstrated this by taking a silver mylar balloon, and he would pull on it. And when you did that, when you pulled it, instead of shrunk it, instead of curving the lens, the image in the center of the silver mylar would expand. And he's like, this is what's going on in the lens. And it was fascinating, because this was the first real scientific conference I'd been at. And I'm sure you've seen this, but most people have never seen this. These guys get up, they yell at each other, they point fingers, they call themselves liars and use four-letter words. It was something like I've never seen before. Passionate fighting against this theory in this case, but I'm sure it happens in other academic settings, which is fantastic. But I just remembered that name, and I wanted to throw that out there to go full circle with that. The problem with a presbyopia drop that acts in another way than the miotic is, I think, it's going to be drug delivery, because if you're breaking bonds, and it's probably going to be disulfide bonds, because I think that's what makes the lens harden over time and eventually become cataractous. But there are also disulfide bonds in the cornea, as the cornea, they make, that's what they do in crosslinking. There's disulfide bonds in some of the retinal molecules that fold and unfold them. So you're not going to be able to use a drop, because there's just too much in the way, too much damage, and then you can't put a needle in the lens and you cause a cataract. So it'll be really fascinating to me to see if they do develop a drop that does that, if they can overcome the delivery problem.
Yeah, no, that's a great point. And in fact, a lot of the innovation that's going on now is in drug delivery systems. We're seeing it's still rudimentary for sure. By the way, that was a great image. And it was a great recollection, because I had forgotten. That presbyopia story really shook me, because Helmholtz was Helmholtz. He basically, how complicated is focusing, is near focusing. To me that was one of the basic elements of the science that defines optometry, that we knew the lens changed shape as part of focusing for near. And all of a sudden this guy comes out of nowhere and says, no, that's not how it's happening. It's not pulling it, it's going to relaxing it, and it's the opposite of what you thought. And I'm thinking, how stupid could we be that we don't know what it is? How could we not know what that is? It's a foundational concept. How can we not know? But it's interesting. I still don't know for sure whether he was right or wrong.
He gaslit us. He gaslit us.
Yeah, probably. I'll go with that. But to your point, I think you're right. I think it's a road with a lot of potholes in it to get to the point where we'll have a truly presbyopia eliminating therapy, and it's not going to be quite that simple. I think the first generation stuff, it's like LASIK. The first generation of LASIK wasn't exactly pretty, but people did it.
When I get presbyopic, I'm going to try it.
yeah. And what I do is I squint. I just squint.
I am wearing multifocal contacts, and they're wonderful for me. And I'm going to tell you that, all they need to do is improve these a hair, and that's good enough for me. And also, it's not something I'll have to put in every day. But to each his own. I'm also a distance hyperope, so different needs than everyone else. Moving along, one of your off the cuffs is simply titled "Off the Cuff: What of Our Young?" And I had to think about what of our young, what kind of grammar you used there, but. It was basically about the importance of leadership. And, you and I at our age have the benefit of hindsight, and we can look at a trail that we blazed and where it got us. All of it, everything that happened in my career was largely a function of where the profession was during that 30 years that I practiced. And optometry is different now. It's not better. It's not worse. It's just different. What trail do you think an Art Epstein graduating in 2021 would try and blaze, as opposed to what you did? How would it be different?
It's interesting. Your comment about the title is funny because the title writes the editorial, and usually it's an idea, and sometimes it could be an idea of I don't actively engage in ODs on Facebook, but I do read it from time to time, and I'll get an idea. It's like you know better than I do probably that time is of the essence. And when you get involved in that, there are people who spend probably half their life on ODs on Facebook. But you have a good reason to. You have to keep an eye on everybody. Someone's got to keep an eye on everyone. So I occasionally will respond to something, but I try to get a sense of what's going on. Plus I do a lot of traveling for speaking and things, so I stay connected with a lot of friends. I get tons of emails. So one of our young is really a concern for the direction of the profession. What are they going to be? Just pretty much the question you asked. I've never looked at it that way. It's a great question. When I was probably in my second or third year of optometry school, I realized that optometry was not an ideal fit for me as it existed back then. But thankfully, I had role models like Jerry Sherman, for example, who also apparently, felt that optometry could be different. I won't say more. Well, I could say more than what it was, because back then it was basically, a 7 and 4 and out the door. Most young optometry students wouldn't even know what a 7 and 4 is probably, but just it was mostly refractive. And I felt I was fascinated by the medical aspects of it. My family was very medically oriented. I got into optometry having a sense that there was that element of it, but there just wasn't enough for me. So I went through had a residency at SUNY, and I got out, and I found contact lenses to be the most attractive for me because it was the most medical, aspect of optometry at the time, and I just felt more comfortable doing that. But as soon as I had the opportunity, I was able to invade organized ophthalmology in a sense. I was very lucky to practice near Eric Donenfeld, who was very OD friendly. He invited me to the local university hospital to meet him, and I spent the day at the cornea clinic. Was really excited. I like teaching, and I had tons of questions from the residents. And at the end of it, he said, "What did you think?" I said, "This was great. These residents are like sponges. They have so many questions." He said, "Did you enjoy it?" I said, "Yeah." I said, "Too bad I won't be seeing them again." He says, "Well, one of the reasons I invited you is, I was thinking you might do this, on a regular basis. I'm here once a month." So I said, yes. Within 2 weeks, I had already hit up his partner to be there on his days. And then I hit up another one of the ophthalmologist cornea guys to be there on his days. And then the residents decided that I was so valuable that I needed to be there on all of those cornea days. And next thing you know, I had created a contact lens service. And I spent, probably about, 20-25% of my time in the hospital, seeing patients and teaching for free without being paid. This was voluntary. And I quickly realized that I was ahead of the curve because I was learning all this stuff from these really bright fellowship trained cornea people. And I was originally very shy. I wasn't a natural speaker, and I realized that I needed to share what I learned, and I found myself on the speaker circuit because of that, largely taking the information I had from a very medically focused orientation, unlike, for example, Bobby Christensen, who is very practically focused because he was in the middle of Oklahoma, sealing leaking corneal holes with super glue that he got at the local Walmart. I was more the histogirl, this is how it's done in ophthalmology, kind of guy. If I was doing this again today, and I was getting out, I would probably do exactly what Corey Lappin did. Corey took a residency, took every moment, every opportunity to learn. He was working with Ed Holland, a lot of really phenomenal people at Cincinnati Eye, and we just by sheer luck happened to meet I think I would have spent a fair amount of time looking for the right practice environment to nurture my interests. And I'm fairly certain that Corey is doing what I would have done, which is his goal was to go back and push the envelope and help pull optometry forward to become even more the primary eye care provider and to make the transition from what optometry was, which was purely refractive, to what optometry will be, which is much more integrated into the medical community as a whole, and much more comprehensive eye care and healthcare. So that's kind of a nebulous answer to your question with a long preface.
No, it was great. It was great. Really interesting story too that I hadn't heard before. I think everybody will appreciate that. We're going to wrap things up soon, but I do want to get back into the personal a little bit. Well, first of all, let me say hi to your lovely wife, Shannon Steinhauser, who's a talented clinician, an optometrist in her own right. And tell us about your family and Shannon, and how'd you guys meet and that stuff.
Yeah, actually, no one's ever asked me that. So that is a good question. No, Shannon and I met by sheer luck. My brother, who I was reasonably close to, is a physician who practiced in Minot, North Dakota. He chose Minot. I jokingly say, although I think it's pretty accurate, because it was the point most difficult to get to from where my parents lived. So, people would say, why not Minot? And for him, it was, because I'll leave my poor brother to take care of my very annoying parents. So he was very successful. A pilot, he was a hunter. I mean, a lot of the things that, I certainly enjoy flying, but, I don't kill things. I don't like kill. I'm sorry?
I was going to say you're a pilot too, I think.
No, I took lessons, but, I was still in New York at the time and realized that I would spend my life on the Long Island Expressway getting to the airport. So I kind of gave that up. And then when I got out here, I said, this is it. There's airports all over Phoenix, Scottsdale. So I was going to start taking lessons. And then I realized the last 3 or 4 commercial flights, I didn't know where I put my bag. So I was thinking, this is perfect. I get up in the air and I go, did I put gas in this thing? So I said, maybe I'm better off being a passenger at this point in my life than becoming a pilot. I don't know if I have the discipline anymore.
Thank you for that.
But yeah, and all the people in houses underneath where I might have flown. So he actually went back to school. He got bored with medicine, went back to school, got a master's in medical informatics, worked for Cerna, which was a big, electronic health record company for a year, got disgusted with the life on the road. We used to compare notes all the time, and then decided that he was going to retire in his early 50s. And unfortunately, as you know, passed away. But he was going to move to Sedona. And I had never been to Sedona, and in fact, he was in the middle of building a house when he unexpectedly passed away. So I decided, when I was invited to speak in Sedona, that normally I would have said, got to drive an hour. What are you, crazy? But I said, okay, I'll go because I wanted to see, what Sedona was, what would have attracted him to move there. And I spoke to the Arizona Optometric Association at their Sedona meeting, and sitting in the audience was this lovely young lady right in the middle on the aisle. I remember every lecture. I remember where everybody sits. I can go back 20 years as I recorded and I play it back to learn from it. It's a very weird affliction. But there was Shannon, and afterwards I went down to listen to Jim Colgane, who was cracking his typical jokes. Yeah,
he's from my area, actually. He's from I'm in Rockville, Maryland. He's
yeah. He was with TLC for a while, but he was on the speaker circuit back then. He used to show all these cute little videos that were always funny. And instead of seeing Jim Colgane speak, I ended up talking to Shannon, and we just kept talking. She's phenomenal. She's an absolutely brilliant clinician. We had a punctal plug emergency the other day where I couldn't get a plug out. I admit it. It was crossover, and I'm just not I'm not good with my left hand. My left hand stinks. So I went and I got Corey, and Corey, of course, ripped the plug slightly. I said, rip, rip. So he knew, enough. So we had to get Shannon, and Shannon did something that I have never seen. And I've watched Eric, Donenfeld do surgery. I've watched, Jay Lippman, a guy who trained under Kelman, do surgery. I mean, I've seen a lot of really good surgeons. This was the most amazing thing I've ever seen. Shannon said, this forceps is a wrong forceps. Get me another forceps. Get me 2 forceps. I need 2 forceps. Now we're going across the nose. She took 1 forceps, lifted the plug, which was split in half, was able to, and this thing was made out of some Russian elastomer, which was insane. I mean, you could probably use a pile driver to compress it. She lifts it up. She takes her other hand, free hand. She comes in on the other side like this and plucks this thing out in one movement. It was the most amazing thing I've ever seen. And I thought this woman was headed for a DCR, but boom, plucked it out. And her technical skills are actually about equal to her clinical skills. Just absolutely brilliant. So from a professional point of view, it's great. And from a personal point of view, she's my soulmate. I mean, I literally, thank God, I got to spend COVID with someone I actually like. We just like being with each other. We don't even have to talk. So I'm very, very fortunate. We have 2 cats. One's 18, and we have a new puppy, which is why I'm incoherent and babbling, because I got 4 hours of sleep last night. It's like a new baby.
That's the good kind of lack of sleep. And I think it's great that you found a woman with mad punctal removal skills. I mean, that's a very hard thing to find, right?
Yeah. Not only that, it's like I'm kind of a fix-it kind of guy. I was the guy that the neighbors would knock on the door at 6 in the morning because their car wouldn't start. And like when I go away and do something, she's always done a project. Oh, we have a new floor in the bedroom. And she does it herself. Like she laid a floor. I helped a little bit, but she laid a floor in her office, a wooden floor. I'm thinking like, this is, but that's the difference between the Bronx and Nebraska. Nebraska, her father is a woodworker. He's just incredibly talented. My father wouldn't even know how to screw in a light bulb. It's like, wasn't in his lexicon of behaviors.
That's a great story. I want to wrap it up, but I want to do that in a special way, and I want to talk for a second about that interview you did with Scott Jens. And in that interview, you talk about your father and how he was the kind of guy who nothing you did was good enough for him. And when you astutely say in that interview that over the years I've reconciled the challenges of my childhood and forgiven my father for never letting me, I'm going to read this, never letting me be good enough for him. And I want to say from my heart and from our industry's heart that you sure turned those lemons into lemonade. You followed up by saying my father actually gave me the most incredible gift. Never being good enough always drives me to be better. And in some ways that's good enough for me. Well, I would say that unbeknownst to your dad, and I'll try not to get cornea as the lame optometry joke goes, but your father gave optometry a gift as well, and your drive to always be better has been a boon for our profession, and we thank you for your continued service, especially for your intellect, your thirst for knowledge, and your willingness to share with everyone. So thank you, Art. I'd love to have you back to continue this talk. There's so many things I can tell we need to talk about, but would you be willing to come back in a few months? I think you said yes earlier.
Oh yeah, absolutely. And listen, let me say something about you. That was very, very, very kind. And I think we all are a product of our parents. And I realized that his difficulty in life, he faced a tremendously difficult childhood, certainly much worse than I ever faced. He basically gave me tools to be successful in a world that he saw as, harsh and challenging. We all are, kind of the apple that fell from the tree. And thank you for saying all those kind of things about me. I want to say a couple of kind of things about you. You literally have changed the face of optometry by creating an opportunity for optometrists to openly communicate with one another. You have more energy than anyone I've ever met. I don't know who changes your batteries every day, but You've also been a straight shooter. I've never seen you do anything that hasn't been for good and for the better of others, and often at your own expense. And so, will I come back? I will insist upon it, and I'm really grateful to have been on here. I apologize to the audience for being somewhat incoherent. I'm not kidding. I literally only got about 4 hours of sleep, so I was kind of prattling on a little bit. But next time I'll probably have 6 hours of sleep, so I'll be less prattling.
I thought it was great.
Ciao tutti. Jim Finelli here, Wilmington, North Carolina, with another episode of the Tuscan Discussion, brought to you by CE in Italy and Europe. Check out our website, ceinitaly.com, for all of our upcoming venues. Today's Tuscan Discussion, we're going to have a topic of retinal vein occlusions. Now, as you know, retinal vein occlusions come in a variety of different formats. We can have a central retinal vein occlusion. We can have a hemispheric retinal vein occlusion. We can have a branch retinal vein occlusion. But all retinal vein occlusions have similar characteristics insofar as the etiology. And as you also know, they are a manifestation invariably of some type of systemic disorder. And it is incumbent upon us to find out what the cause of that systemic disorder is. The majority of patients with vein occlusions, especially branch vein occlusions, do not have macular edema. Those individuals with branch vein occlusions or hemispheric vein occlusions or central vein occlusions that do in fact have macular edema would benefit from anti-VEGF therapy. And those folks are ultimately going to need to be in the hands of a retinologist to administer the anti-VEGF therapy. However, treating the macular edema is only a part of the process. Again, this whole vein occlusion event is a manifestation of an underlying systemic disease. So before we begin treatment of the macular edema, we need to get to the root cause of the problem. And that's what I want to talk with you about, because the workup of patients with vein occlusions is certainly within the wheelhouse of optometry. So the basic question is, in all vein occlusions, what's the underlying pathophysiology? Now, I know a lot of you are going to immediately default to hypertension. Keep in mind, hypertension causes structural changes in the arterial system. Of course, retinal vein occlusions is an occlusive disease that occurs in the venular system. So the venular system is not directly affected by hypertension like the arterial system is. But as you know, the retinal artery and the retinal vein system lie in close proximity to each other in the retina. We have arteries taking blood into the retina. They fan out from the central retinal artery, primarily along the superior and inferior temporal arcades. Those capillaries that are fed by those arteries begin to join. They form the retinal venular system, and all that blood is ultimately heading back toward the optic nerve. But in the course of the retinal vasculature, more often than not, retinal arteries lie on top of retinal veins. And keep in mind the histology of retinal arteries. Their walls are elastin. There's smooth muscle fiber in these walls. So they are much more prone to adaptation due to structural pressure differences, such as what we see in hypertension. Venular walls are much more flaccid. So think of a venular wall as being very, very soft and susceptible to compression by a harder walled retinal artery, which most of the time lays on top of those retinal veins. When we have a retinal vein occlusion, whether this is a central retinal vein occlusion, whether this is a branch retinal vein occlusion, or whether this is a hemispheric vein occlusion, there is a thrombus that forms in that vein. And that thrombus that forms is what causes further narrowing of that vein, and therefore a backlog of blood behind that thrombus. The question is, what is causing that thrombus? For example, in patients who have hypertension or elevated cholesterol or diabetes, or the 5 main risk factors for atherosclerosis, diabetes, high blood pressure, elevated cholesterol, smoking, and obesity, these individuals undergo structural changes in the arterial system. And those structural changes in the arterial system begin to compress and press on and distort the exterior wall of the venular system. So that vein that was normally flaccid but tubular now has a distinct compression in it. And it is that compression in the vein that is not completely closed off, okay? It's just narrowed down, but that narrowing of that venule causes the blood flow through it to become slower and perhaps a little bit turbulent, and that sets the stage for a clot formation. That's the thrombus. So retinal vein occlusions oftentimes come from a thrombus more often than not at an artery vein crossing, whether that's in the retina or behind the lamina in the optic nerve. But because of this thrombus formation, this venule that used to be like this is now somewhat depressed, flattened. Part of it is now occluded with the thrombus. That vein still has blood flow through it because we know that blood is still getting into the eye. The eye is still functioning. It's malfunctioning, but it's still functioning. That blood is getting into the eye. It's just having a hard time draining from the eye because that venule now has been compromised and partially occluded with the thrombus. What ultimately is causing the thrombus? Therein lies the question. In those individuals who have atherosclerosis, hardening of the arteries, development of atheromatous plaques in the lining of the arterial walls, if we see a vein occlusion with some compression and perhaps AV crossing changes in other areas of the retina, chances are very high that what caused that vein occlusion is an artery compressing that venule, and then, because of that compression, a thrombus forming. So one of the more common causes of all forms of vein occlusions is atherosclerosis. And keep in mind, the atherosclerosis is affecting the arterial end of the system. And the structural changes that occur in the arterial end of the system are compressing and causing secondary structural problems to the venular end of the equation. And the majority of our patients that are in their 50s and 60s and 70s who present with retinal vein occlusions typically have as the underlying cause elevated blood pressure, elevated cholesterol, diabetes, hypertension, smoking, obesity, etc. Those types of things. But what happens in an individual, for example, who is younger, who presents with a vein occlusion, who doesn't have any overt signs of atherosclerosis? There's no findings in the retinal tree. We have this wonderful retinal tree to examine all these crossing changes, both the right and left eye, for signs of atherosclerosis. But when we don't see atherosclerosis, which would be certainly a contributing factor for certain vein occlusions, When we don't see the atherosclerotic changes, but we see a retinal vein occlusion, the question then is, well, what in the world is causing that vein occlusion? It still goes back to a thrombus forming, and that thrombus can be forming in a branch retinal vein, a hemispheric retinal vein, or the central retinal vein. But what can cause a thrombus in an otherwise healthy individual? If we see that, if we see a retinal vein occlusion without the associated atherosclerosis, we need to then start thinking about the possibility of hypercoagulable syndromes that are inducing clotting in this individual. And those hypercoagulable syndromes can fall primarily into two categories. One is antiphospholipid antibody syndrome. It goes by a couple of different terminologies: anticardiolipin antibody syndrome, and that's typically, I call it antiphospholipid antibody syndrome. This is an autoimmune disorders whereby certain antibodies, in particular anticardiolipin antibodies, are produced, and these anticardiolipin antibodies increase coagulability in these individuals. And these coagulabilities and these thrombi can form in both the arterial system and the venular system. So if you have a young lady, for example, who presents with a vein occlusion, one of the things we need to think about is antiphospholipid antibody syndrome, especially if this young individual has had a history of miscarriages, because oftentimes antiphospholipid antibody syndrome is undiagnosed, and that may be the ultimate cause, certainly, of the miscarriages and certainly of the retinal vein occlusions. Another condition that can cause retinal vein occlusions is a genetic condition called factor V Leiden. This is an inherited autosomal dominant condition whereby these individuals just are prone to coagulation. So in the context of retinal vein occlusions, you have an otherwise healthy individual with no overt retinal signs of atherosclerosis. Factor V Leiden may ultimately be the culprit. And this is typically found in individuals of European descent. So, how do we manage these individuals? And I'm going to simplify this into those vein occlusions caused by atherosclerosis versus those caused by hypercoagulable syndromes. For individuals who have hypercoagulability, the standard labs include a CBC with differential. For example, things like sickle cell anemia can also cause vein occlusions. And a CBC with differential is an elegant, simple test that's going to pick up 90% of hematologic disorders. But if we have an individual who doesn't have the atherosclerotic changes in the presence of a retinal vein occlusion, antiphospholipid antibody syndrome needs to be considered, and that's going to be done, or that's going to be established lab-wise with an ELISA test. And then the factor V Leiden, labs, genetic labs, are going to ultimately be determined by the individual lab provider that you're using. So CBC with the coagulable labs are in order for those individuals. For individuals who have atherosclerosis as the suspected underlying condition, they of course need to have their blood pressure checked and under good control. They need to have their lipid profile checked and under good control. And these are individuals who would probably benefit from a stratified lipid protocol. In other words, those subtype particle lipoproteins, in particular the bad LDL lipoproteins. So ASCVD, atherosclerotic cardiovascular disease, these individuals have retinal signs. They have probably disseminated vasculopathy throughout their body. So the risk factors for progressive atherosclerotic cardiovascular disease, again, are hypertension, diabetes, and elevated cholesterol. Those three things need to be well controlled in order for the vein occlusion to begin to resolve. Again, some vein occlusions are going to come with macular edema. Those folks need to go to retinology so that they can have anti-VEGF therapy. But for those individuals without macular edema, that's our job to find out what is out of kilter. Is it the patient's cholesterol level? Maybe they're on a blood pressure medicine, but maybe their blood pressure isn't quite as well controlled as it needs to be. Maybe they're on a statin, and maybe their lipids are not quite as well controlled as they need to be. Patients with atherosclerotic cardiovascular disease oftentimes have elevated homocysteine levels, so that certainly needs to be checked. So atherosclerosis can induce retinal vein occlusions due to structural changes in the arteries, secondarily affecting the venular system, and hypercoagulable states in younger, healthier individuals can also cause retinal vein occlusions. Hopefully you got a little snippet or two of information from this. Come join us with our CE in Italy programs in 2022. We are heading to Barcelona, Florence, the Greek Isles, Budapest, Prague, and of course, Tuscany. So again, ciao everyone. Thanks for sticking around and hope you got some information out of it. Visit us at ceinitaly.com. Ciao, ciao.